Good afternoon. So we're going to start the afternoon session with some enrichment topics. There's a couple that have been suggested from last year. So the first one, I will be talking about risk assessment guidelines. How well do they perform in selecting patients who are at high risk and otherwise would be eligible for treatment, such as with tolvaptan. This is my disclosure. So I just want to follow up with Dr. Torres, and that now we have one approved treatment, tolvaptan, for ADPKD, but who are the patients that we should treat? And he also had listed that depending on the country, the different rates of selection criteria, like different criteria, and some are more specific, some are less specific, and but the overall idea is that one should select patients who are at high risk for rapid progression. So just repeating some of the slides as well. And so we know that tolvaptan is a drug that now had been shown to be effective in slowing disease progression in a couple of large-scale clinical trials. And also the patient who may benefit from it, if they have higher kidney function at the time of treatment, they may benefit more than if they were started on treatment at lower level of kidney function. On the other hand, the drug is expensive and has potential for serious toxicity. And so I think one needs to gauge the risk and benefit ratio in order to select the appropriate patient for this drug treatment. And when we think about risk assessment, you already heard about using kidney volume as a marker, a little bit about genetics. Dr. Torres talked about the use of genetics to delineate the average risk in a population, but there are problems of applying that to the individual patients. So I want to touch upon each of this a little bit. Kidney volume increase with age and disease progression, and it's a kind of validated marker for assessing progression. And you have seen these slides earlier, and using age and the high adjusted kidney volume, we can predict risk, different category of risk that are associated with different rates of progression using the Mayo Clinic imaging classification. Mutation information also is useful when you look at a large population of patients. This is 220 families that we study in Toronto with genetic screening, and that you can see about 1/3 of them had this protein truncating mutation, and another small percentage of PKD1 insertion deletion. Both of these group of patients tend to have much more severe disease than, for example, the PKD2 patients. And you can look at the population level from these 220 families. We were able to recruit 780 patients, including their family members. And if you look at the kidney survival as defined by absence of the need for dialysis or transplantation, then if you have a PKD1 protein truncating mutation, then on average, half of the patient would need dialysis at around age 50 to 55. By contrast, PKD2 patients, half of them would need dialysis when they're in their 80s. And in between the different subtype of PKD1, the in-frame insertion deletion and the non-truncating PKD1 mutations. However, one thing we notice is that within family, there's a lot of variability. And this is a point that Dr. Torres was mentioning. In this case, we look at individual families that we have studied in Toronto, and each line represents a family, and each dot an affected relative, and the age of needing dialysis is plotted on this axis. So you could see in this family, 2 members require dialysis at about 50 or below 50 years of age, but another member did not require dialysis well into the 80s. So you can see this kind of extreme variability, making mutation as a risk prognostic marker not 100% reliable. So as guidance to nephrologists how to assess risk, there are 2 guidelines that had been reported in the literature, one by a group of Canadian nephrologists, and this is the revised guidelines. There's a couple of revision already, and so the expert consensus in assessing risk of disease progression in polycystic kidney disease. The other you mentioned, the other you have heard of already by Dr. Torres is the European guideline by the ERA EDTA working group. And I'm going to talk about how this guideline perform in a real-world cohort of patients. So our underlying assumption is that if these guidelines are good, what should they achieve? But before we can answer that, we have to have some kind of gold standard. And we decided to use the Mayo Clinical Imaging Classification, the 1C to 1E category, as defining the patient who are at high risk progression. This classification system had been validated in several studies, and it's an accepted by the FDA as a patient enrichment tool. And then we also want to assess the 2 sets of guidelines by the Canadian nephrologists and European nephrologists. And our assumption would be if these guidelines perform well, they will enrich a high proportion of high-risk patients using the definition as defined by the Mayo Clinic Image Classification. At the same time, exclude most low-risk patients. And if the guideline perform this function well, then they will provide most clinical utilities. So we actually use a cohort of patients we have studied in Toronto. For the past, I guess, 2.5 years or a little bit, we had studied 500 patients, and every patient that come to us, we offer them the kidney imaging and genetic risk assessment, and this information then can be used to assess the risk of progression. Some patients were excluded due to not having enough EGF data or a typical Mayo Clinic classification class 2. And the final cohort of study we used to evaluate the clinical guidelines comprised of 474 patients. And so these are the characteristics of patients. They are in the mid-40s and with fairly good eGFR and kidney volume, high adjusted around 700 ml per meter. So first, we want to look at the Canadian guidelines. So this is the updated recommendation. But essentially, this group of nephrologists, they took the idea that if patients fulfill the enrollment criteria for these 2 landmark clinical trial, Tempo 3, 4, and Reprise trial that tests the tolvaptan effect, if they satisfy either of these enrollment criteria, then they would be considered at high risk for progression and then therefore would be eligible for tolvaptan therapy. So how well do these guidelines perform? So from our cohort of patients, if we use the Mayo Clinic imaging class as a gold standard to define who is high risk, we have 61% of the patients considered as high risk by the Mayo Clinic imaging classification using 1C to 1E. If these patients, this whole entire cohort, undergo the Tempo 3-4 criteria, they could fulfill the criteria or not. And in the case when they fulfill the criteria, they would be selected out as high risk. If not, they would be excluded and then to be reconsidered under another set of criteria. And I will talk about that a little bit later. So in this first step, using the Tempo 3-4 criteria, the guideline capture 55% of the high-risk patient that would be suitable for tolvaptan therapy. But at the same time, 9.6% of the low-risk patient, the 1A, 1B, would also be misclassified as high risk and exposed to tolvaptan treatment if you use this guideline as selection criteria. Having gone through the first step, those who are excluded in this first step will undergo another filtering process using the reprise criteria for the second study of tolvaptan, and they could either fulfill it or and not. And those who get selected because they fulfill the reprise criteria as shown here. So if you use both of these guidelines, then you can select these two groups of patients and in essence capture 70% of the high-risk patients according to the Mayo Clinic imaging class. But at the same time, expose 14.5% of the patient who would be regarded as low risk to therapy. So this is how we find the Canadian guideline perform if we do this exercise. How does it compare to the European guidelines? So European guidelines are a bit more complicated and it's multi-stepped. And I think the design of the guideline took into consideration that they thought, the nephrologists in Europe thought that they are unlikely to have high access to the kidney volume-based risk assessment, and so they heavily rely on the kidney function as a different age strata to select high-risk patients that are thought to be at risk for progression. So Dr. Torres already shown this step, this first step, and depending on what age and what the eGFR or kidney function level, and it may get selected or it may get rejected. The ones that patients who did not fulfill this criteria, they will get excluded and considered as slow progressor based on the eGFR consideration, and not recommended to have any treatment. The ones that get selected at this step, if then they can look at additional steps, including the rate of decline in the kidney function, and then if that, then that can filter out the ones that did not fulfill the criteria, or the ones that get fulfilled will also can be considered for additional steps. And I didn't want to go into the additional step because when we do our analysis, most of the patients actually get excluded after 2 steps, and so the other step may not be that relevant. So what does this result show? Somehow my slides is changed a little bit. The formatting seems to be a little bit different. Okay, so anyway, so again, using our cohort of 474 patients, remember 61% would be considered by the Mayo Clinic classification as high risk. If you use the first step of the European guideline and it fulfills the first step, then you get selected. If you didn't get through the first step, you get excluded. And so the first step of the algorithm actually exclude more than 2/3 of the high-risk patients because they didn't satisfy the age, strata, and CKD stages. Okay, so 2/3 of the high-risk patients get excluded and would be considered as low risk under this schema. And then the second step, looking at the rate of change, patients who have higher rate of loss of kidney function. Again, it would exclude patient or include patient depending on that. And, but if you apply the second step, it excludes another 20% of high-risk patients. So what do we have? In the end, what we find is that only 11% of the originally high-risk group get selected after 2 steps as high risk. And then the assignment of low-risk patient as high risk, the percentage is low. But the main message is that most of the high-risk patients actually get excluded after 2 steps. And if the intention is to identify high-risk patients, then the European risk assessment algorithm would actually not perform very well. So 90% of the high-risk Mayo Clinic imaging class patient would have been excluded at this. And we didn't take this exercise further because there are very few patients left for the other steps. Why do these patients not get selected, the high-risk patient, if you just use eGFR? And so we have the opportunity to kind of look into this, and I think I seem to have a formatting problem with my slides. If you look at patients by their kidney volume, large kidney are shown here, smaller kidney down here, and looking at the kidney function, normal kidney function in this range, decreased kidney function on this range, you can kind of break the patient into 4 quadrants. Those who have large kidney and low kidney volume is here. Large kidney volume and low kidney function are here. These are the bad patient at advanced stage of disease. Those who have big kidney but normal kidney function are here. Those have bad disease, large kidney volume, but relatively early disease stage that have not yet progressed to kidney failure. This group of patients have low kidney volume and normal kidney function. So they would tend to do very well because the kidney disease is mild. And there is a group of patients that have low kidney function and their kidney volume is not large. And so what's going on? We already seen some of these cases early on, including one of the case presentation that showed this discordance of kidney volume with more impaired kidney function. So that could be an explanation. But this group of patients is quite interesting, and we try to understand what's going on. And then when we look at them more closely, what we find is about 30% of this group of patients, when we look at the estimated GFR under 80 ml per minute and compare it with the measured creatinine clearance, the measured creatinine clearance is about 20 points higher than the estimated GFR. And many of these patients actually with this discordance due to the measurement method of kidney function, when we review the imaging pattern, are very consistent with mild disease. So suggesting that eGFR may actually underestimate the disease burden and kidney function compared to the measured creatinine clearance. I think additional work needs to be done to use independent methods that are more accurate to reflect the true kidney function or GFR rate, and I think that we need to work on it a little bit. The other patients that also fall into this group tend to be like the patient that was in one of the cases, the second case that had the discordant, the cystic kidney disease by the imaging pattern appear to be mild disease and the kidney function, and yet is more severely depressed than would be expected. And I think this is a very heterogeneous group of patients, They could include patients who have a second kidney disease, diabetic nephropathy, glomerular disease, and or maybe renal vascular disease, or other forms of cystic kidney disease that are not due to PKD1 and PKD2 mutations. And Dr. Torres already mentioned some of these mutations, and there are some gene mutation in which the cystic disease burden is not necessarily reflected by the size of the kidney, and yet they can have more severe degree of kidney failure. And this group of patients probably will be picked up in the future when we use this kind of gene panel and kind of analysis to look at multiple genes beyond just PKD1, PKD2, and then looking at potential modifier genes or non-ADPKD kind of gene mutations. So I want to kind of sum up to say that risk assessment in ADPKD is an evolving process and needs to be refined by new clinical data and test technology. But in our center, we use the Mayo Clinic imaging classification because we feel that it likely provides a single best risk assessment tool at this time. Gene-based testing, we do it routinely for research, but it's less reliable at the level of the individual patient because of the significant modifier effect. The familial variability is a reflection of modifying effect, and we don't quite understand what is the basis of this modifier effect. We suspect that it could be due to other genetic factor and as well as environmental factors. I think that the performance of the risk assessment guideline need to be evaluated and validated by real-life clinical data. The consensus by a group of nephrologists is a good start, but when real-life data are available, I think those will need to be fed into further refinement of guidelines if they choose to revise them. But we do feel that actually the Mayo Clinic classification really is very simple to use. I think it does require the diligence to get accurate enough volumetric assessment using CT scan or MRI, and there are protocols that could be applicable for translation in the clinical setting, and we will have the opportunity to discuss this a little bit later today when we talk about the setting up PKD center or PKD clinic, what are the critical elements. And finally, guidelines that enrich high-risk patients while minimizing low-risk patients have the most clinical utility. So right now, I would say that both the Canadian and the European guidelines are not quite ideal like in fulfilling this task. And this is just an acknowledgement slide for many people who have been helping for this analysis.